now.
Thank you very much, Prof. As you can see, I take breast cancer very seriously. And so I'm in my pink t-shirt as we prepare for Pinktober. I will try as much as I can to introduce us to breast cancer access and what the future of breast cancer looks like. Please join me. It's going to be quite a ride. But I'm sure that by the time we are done, we'll be more conversant with breast cancer in our context. And also, since Pink October is coming, we'll be prepared for the numerous questions that our patients and the general public, including the media, will be bombarding us with. They've already started with asking about gel nail polish. So get ready. It's going to be a Pink October to remember. My job is to give an overview of breast cancer in Ghana as we prepare for Pinktober. Give me a second, let me go on to the slide mode. Perfect. I hope you can hear me and you can see my slides as well.
Yes, we can.
All right, so breast cancer is a peculiar disease. Sorry, give me a second. And it's peculiar because of the way it starts, but also because of the way it's managed. It's not like our usual diseases where there's a particular organism that you can target. So once you kill that organism without causing harm to the human body, then your patient is well. It's not quite like that when it comes to breast cancer. And changes that result in breast cancer will usually start at the subcellular level. So changes in DNA, changes in RNA, which you may be born with, or which may occur spontaneously, may occur due to physical causes like ultraviolet ray radiation, or from infective causes, viral infections, some protozoal infection, even some bacterial infections, like we have in cancer of the stomach, and some chemical causes. So polyaromatic hydrocarbons, for example, we know are associated with cancers like cancer of the lung, cancer of the head and neck region. Now, once these changes have occurred within the cell, then the cell over time is able to accumulate certain capabilities that are essential to ensure that that abnormal cell is able to metastasize to other parts of the body and so becomes a malignancy. This has been deeply researched by Hannan and Weinsberg, and they've described initially 6 hallmarks of cancer. But over the years, the number has increased, and I'll show you a few more. So this is the original 6, where cells develop the ability to sustain proliferative signaling. They have the ability to evade growth suppressors. They developed the ability to invade. So they break from the original cells and then burrow through blood vessels and travel to other sites via metastasis to go and affect those sites. The other important hallmark is enabling replicative immortality, where they produce telomerase so that the telomeres at the end of the cells do not shorten, and so the cells will not die. They also induce angiogenesis, however bad the blood cells may be, but it's enough for them to get growth factors, etc., and so to move to other sites. And then they have the ability to resist cell death. Now, the new hallmarks include deregulating cellular energetics. So if you are in cancer at all, you would have heard people talk about the fact that if you're able to avoid sugar, you'll be able to kill your cancer cells. Well, cancer cells develop deregulating cellular energetics, such that in the absence of glucose, they will use it. In the absence of oxygen, they will do anaerobic respiration. So that's one of the special things to it. They also avoid immune destruction. And this is really important as we talk about the current treatment for breast cancer. You would see that if you are able to overcome this, then the body's immune system, which ordinarily does not have real use when it comes to breast cancer, then becomes activated to control cancer. It's also important for cells to develop tumor-promoting inflammation. Once there's inflammation, there's increased cytokine activity, tumor growth, platelet-derived tumor cells transforming growth factor, beta, etc., and the cancer cells are able to go. And then the other thing is genomic instability and mutations. With more genomic instability and mutations, then the cell is able to overcome all of the resistance that the body would usually put up, but also develop resistance to the drugs that we introduce in an attempt to control the cancer. So when it comes to cancer statistics in Ghana, it is the commonest cancer in Ghana. Breast cancer is the commonest female cancer in Ghana. It's the same for the rest of the world. From my center, which is the National Radiotherapy, Oncology and Nuclear Medicine Center of the Korle Bu Teaching Hospital, in 2024, there were 758 new cases that were diagnosed. And by the end of June this year, we had 358 cases. Last check, we are close to 600 cases. So you can imagine that by the end of 2025, we'll have more than the 758 we saw in 2028. According to GloboCan, there are over 5,000 new cases that were diagnosed in 2022. And you can agree with me that most likely these are not real figures, because the truth is that GloboCan uses data from various sources, including cancer registries. Unfortunately, in Ghana, our cancer registries are not robust enough. In fact, I think for the Accra Cancer Registry, since post-COVID, I'm not sure if we've been able to collect any data. The Kumasi Cancer Registry has its problems as well. So this is an underestimation, if there's anything to say. And I know that most of the cancers will go to Accra and to Kumasi, but there are other sites where cancer is treated, even if they are not the most important sites for treatment of breast cancer. I put this image on to show you just how wide apart breast cancer is from the other cancers. The second most common is cervical cancer, but breast cancer is 2,000 more patients than cervical cancers that were diagnosed in 2022. And the trend seems to continue. I don't know if it's because we are talking more about breast cancer, and so more patients are coming to us, or really that we have more breast cancers in the country. I also put this image on because even though new cases are important, and that's one of the things that we are monitoring, because we are able to give good treatment to our patients, the number of prevalent cases for all cancers are going up. A lot of it driven by breast cancer, which is the commonest female breast cancer. So you are not only taking care of people with new diseases, you also have to fashion your healthcare system to take care of the people who've been diagnosed with breast cancer and are cancer-free or will develop cancer sometime after the diagnosis of their initial breast cancer. So as a quick overview, you know that the breast is an accessory sweat gland. It has two parts mainly, a glandular part and the stromal tissue. Now, the glandular tissue is mainly made up of the milk-producing structures and their ducts, and those are the sites of origin of cancer. So ductal carcinoma arising from the duct and lobular carcinoma from the lobules. And then there's the stromal tissue, which gives it structure. So there's fats, there's ligaments, etc. But also importantly, there's a rich supply of lymphatics, which results in distant metastasis of breast cancer. So the commonest site of initial metastasis is the axilla, for example, and the supraclav and internal mammary other sites as well. Now, what are the risk factors for breast cancer? There are various ways of looking at it. You can look at it as the modifiable risk factors, the non-modifiable risk factors. You can look at groups of causes as well, so hereditary or gender-related or reproductive-related, you can do that. But the most important ones are advancing age. Majority of our cancers are seen in women over 40. I don't know how many women below, say, 30 years that you've seen with breast cancer. There are few, but majority of them are diagnosed in women with advanced age. And then the female gender. These two, advancing age and female gender, are the most important. And so when people talk to you about what did I do, etc., I often tell them that, well, you are growing and you're a female. These are things that you can do nothing about. And those are the reasons why you may have developed your cancer. But there are others as well, reproductive factors, including age at first child, age at menarche, age at menopause. The longer the time where you're exposed to estrogen, the more likely it is that you may develop breast cancer. Nulliparity is associated with breast cancer as well. And for the age at first child, the most important is that for women who have kids after age 35, the risk is higher, probably more than the rest of the general public, more than somebody who's nulliparous, for example. And then whether you breastfed or not, breastfeeding has been associated with some protection from breast cancer. So if you haven't breastfed before, then you have a slightly higher risk. Family history is important. Everybody knows a family where they appear to continue to have breast cancers. And there are several deleterious gene sequences that have been found, BRCA1 and 2, live for many due to P53 mutations. And then we found recently that, that increased mammographic breast density is also associated with development of breast cancer. Obesity, sedentary lifestyle, these are modifiable risk factors. They are associated with increased risk of developing breast cancer, as well as alcohol consumption and cigarette consumption, especially when the two are done together. Now, what's peculiar about breast cancer in Ghana is that the age at diagnosis seems to be younger. Whether this is true or not, well, a country that has a young population, you can imagine that the proportion of women between age 40 to 50 is higher compared to, say, 50 to 60 and the older age group. And so it's not surprising that our breast cancer peak age appears to be between 40 to 50 years. And we also appear to have more aggressive disease. And this cuts across the Black race, whether they are African Blacks or Blacks in the diaspora. And majority, well, a lot more Blacks appear to have triple negative breast cancer, which is a more aggressive type of breast cancer. And in fact, there's some evidence that even for hormone receptor positive breast cancer, which is traditionally seen to be of favorable outcome, in Black people, the outcomes are slightly low. And it's not just because of poor access to treatment. Unfortunately, another peculiar thing about breast cancer in Ghana is that our patients come to us with advanced disease. And there are various factors. That alone could be a topic for Bisayan to discuss. But there are so many of them. There are patient-related factors. We know for sure that our patients lack knowledge. Up till now, you see people who would say, I never heard about breast cancer. There are competing treatment options because we have our own ideas about the causes of disease. And so we seek herbal care, we seek spiritual care, sometimes delaying proper interventions. And then we have health system-related factors as well. We don't have a screening program as a country. And so you can imagine that if your doctor is not proactive, or if the patient, a patient does not advocate for themselves, then they may go through the healthcare system, never doing a mammogram or even a pap smear, which could be life-saving. And then late diagnosis, even when the patient has come to hospital, because breast cancer is the last thing on your differential diagnosis. Once we've found it, referring the patient is tedious, especially when you're coming from outside of Accra, Kumasi, Takra, Disunyani. Sometimes it's easy to think that Ghana is Accra, Kumasi, and the capital regions. It's not. And so sometimes even when patients have been diagnosed, getting them to the referral site is a problem. And then we don't have enough trained personnel, obviously. We don't have enough oncologists, enough pathologists, enough surgeons. The list is endless. And then there are socioeconomic factors. Treatment of cancer is not cheap, not in Ghana, not in any part of the world. And that may be a reason why people will not seek treatment. We don't have enough treatment facilities. And when I talk about this, I mean distance to the treatment sites. And then lack of social support. Elsewhere in the world, when you've been diagnosed with certain diseases, the system actually supports you to make it easier. Your journey in the UK, they'll give you transportation. Even if the treatment facility is not close to you, they offer you transportation to take you there just to make the whole experience more tolerable for the patient. Outcomes for breast cancer have improved tremendously, and there are various reasons for this. We've had such a drastic paradigm shift where the one-size-fits-all has been completely abandoned. And currently, patients are receiving personalized and precision treatment based on investigations and outcomes. And also, we have improved diagnostics, so radiology. We have improved pathological services like molecular subtyping and genomic expression profiles that are able to tell us which groups of patients require specific treatments and those who will benefit from those treatments, so that we don't give side effects without any real value. Now, all of this has led to better tumor characterization and efficient targeting, leading to fewer treatment side effects. Now, once we are able to properly identify the disease that the patient has, we are able to de-escalate certain treatments, so de-escalated surgical techniques, moving from mastectomies to wide local excisions. Axillary surgeries have moved from level 2 dissection to now doing sentinel lymph node dissection and targeted dissections. And radiotherapy equipment are now delivering treatment with precision, ensuring that the tumor receives most of the dose while surrounding tissues are spared. And then there's efficacious medications. I have a graph I would show that shows how we've moved from less efficacious drugs to more efficacious drugs and how combining them are useful. And then these days, there are survivorship programs, even if they are not as well established in Ghana, but these programs, whether it's support groups, etc., they are able to help the patient so that the extra life you give them by intervening is more useful. You're not just adding years to their lives, you are actually adding life to the years that they have to spend, even for patients who have metastatic disease. And palliative care has been found to be the cornerstone for this. Most of us know what the symptoms are for breast cancer. So clinically, majority of your patients will present to you with a lump in the breast or a lump in the axilla or both. Now, I put breast self-examination here, not because it's part of your clinical diagnosis, but because it's important when you're taking your history. There have been patients who have insisted that they think there's something wrong with their breast, and the doctors have insisted that there's nothing. But somebody who does self-breast examination knows their breast well. They know the texture, they know the cyclical changes, they know the size, and they know the skin conditions. So this is just a warning that if somebody comes to you and continues to say, I think there's something wrong, please, if it means doing a mammogram for the patients, do that. But also clinical breast exams to examine the mass that you've seen in the breast or in the axilla, whether it's hard, whether it's fixed, whether it's attached, whether there's nipple discharge, retracted nipple, ulcers on the skin, podorange. But I also want you to remember that sometimes your patients will present to you with no changes in the breast at all. And this is when we want to see our patients. These are the patients who will come to you with screening, mammography, etc. Pay attention to them as well. Now, the use of radiology in breast cancer treatment is threefold. I was going to say twofold, but actually it's three. It's useful for screening, so to identify the disease in people who are at risk but do not have any clinical evidence of the disease. It's also useful for diagnosis. So when you've found a mass and you suspect that it's a malignancy, radiology is useful to identify features that suggest that it's a malignancy. But these days, it's also interventional and therapeutic, so that certain abnormalities that are seen in the breast using vacuum-assisted mammograms, these can actually be taken care of, and that will be the end of the treatment for the patient. When it comes to screening, it's done in an at-risk group, and it's useful because it's able to detect the disease at a very early stage, including stage 0 disease, which is the non-invasive breast cancer. These would eventually develop into invasive disease. And so if you catch them at that stage, then you are truncating that journey into development into invasive breast cancer. And then when you do mammograms as well, screening mammograms, the odds of finding early stage disease when it's invasive is high. At this point, treatment is more effective. You are able to do less mutilating surgeries, and even the intensity of systemic therapy is not as much as when you find diseases that are more advanced. And all of this will translate into reduced tumor-related morbidity and improved survival. For diagnosis, mammography is effective for characterizing changes in the menopausal breast. Once you become menopausal, there's involution within the breast. All of your glandular tissue, at least most of it, becomes replaced by fat, so that the low energy mammogram is able to actually look through the breast and to identify whether it's a mass or calcifications that are significant for cancer. And then there are different types as well. The digital mammography and 3D mammographies are an improvement on the conventional one. They are able to show the abnormalities more clearly so that we don't miss people with cancers that may be hidden. And then these days, ultrasound scans and MRIs are complementary. If you have any finding that is not clear on the mammogram, these two may be useful in vector characterizing them. And the BI-RADS classification is what is used for this characterization, starting from 0 all the way to 6, from when you cannot actually assess the breast appropriately to when the cancer has already been diagnosed and you're just characterizing the lesions that have been found. Have a look at the BI-RADS classification. And then there are other investigation tools as well, X-rays, CT scans, diffusion-weighted MRI scans, multiparametric MRI, bone scans, depending on what the patient presents with, PET scans, which are the new kids on the block, as my prof would say, Prof. Vanderpoel. And it's useful because it's able to identify occult metastasis, metastases that we thought were not there, but actually are there because it uses physiologic means to detect activity, cellular activity. And they're also useful for identifying recurrences when they do come, as well as sites of distant metastasis, even in recurrence. So this image just shows you the difference between the conventional 2D mammography and the 3D mammography. I don't know if you can see my cursor, but you can see that this area looks a little bit suspicious. However, to the common eye, you might think there's nothing there. This is a 3D mammography, and that clearly identifies abnormal lesion in the breast. Pathology has evolved quite a bit as well when it comes to breast cancer. And in the triple diagnosis of breast cancer, without your pathologic diagnosis, you probably cannot make a diagnosis. But since I've mentioned the triple diagnosis, I just want to state that sometimes all three will not point to malignancy. We've seen many patients who have done mammograms that suggest that the lesion found may be benign and may not even require biopsy. But you must use all the knowledge you have, including what your ancestors will tell you. Because sometimes you see a 40-year-old, they are told they have a fibroadenoma, and you are convinced 40 years fibroadenoma, probably not. Probably they do not have fibroadenoma. So by all means, make sure the triple diagnosis is used, but where one does not fit, if you are still suspicious, go on to do the biopsy. And the biopsies are important because they give us not only prognostic information, so how the cancer would evolve, the natural history of the cancer, but it also gives us predictive information so that you're able to determine whether this particular cancer will respond to, say, hormonal therapy or targeted therapy with trastuzumab, or even immunotherapy because they have high tumor mutational burden. Then there's histological types. There's the invasive carcinoma, no special type. And there are the special types as well, mucinous, medullary, etc. And be aware that the different histological types have different prognosis. So, for example, mucinous breast cancer, medullary breast cancer, they are usually of good prognosis. And so your patient is likely to do well, for example. And then there's immunohistochemistry that identifies the receptors on the cancer cells, estrogen receptor, progesterone receptor, HER2 status, as well as proliferative indexing. So your Ki-67 values, which are very important and are useful for categorizing your luminal cancers, especially into luminal A or luminal B. Have a look at what the different types of luminal breast cancers are. But those are the hormone receptor positive ones. And whether or not it's has high proliferation will be a luminal A for those with low proliferation, and luminal B for those with high proliferation. And then there's the HER2 positive subtype, the HER2 enriched, and the basal type, which is the triple negative breast cancer. And then there's genomic testing as well, whether germline or somatic, to identify those who have inherited risk of breast cancer, but also those who developed damage to the BRCA gene and so may respond to certain medications. Genetic profiling has become very important, especially for hormone receptor positive breast cancer. They analyze multiple genes. They include the MammaPrint, Oncotype DX, EndoPredict. All of these will help you to determine patients who would benefit from chemotherapy addition or not. And it's very important for tailoring the treatments to your patients. Staging of cancer is awfully important. It's prognostic, and these days it helps us to determine how to treat the patients. The commonest way of it is the AJCC staging that uses the TNM classification, T describing the tumor, so the size and local involvement, N assessing nodal involvement, and then M, which describes distant metastatic involvement. And it's also useful to categorize your breast cancer patients into early stage breast cancer, which is usually T1 to T3, T0, T1 to T3, N0 to N1. Any other ones are said to be locally advanced, and then you can have your metastatic disease when there's evidence of distant metastasis. Surgical treatment for breast cancer has also evolved quite a bit. We've moved from doing the Halsted surgeries where even the chest wall was removed in an attempt to control breast cancer to now doing just modified radical mastectomy, but also wide local excisions in what is described as breast conserving surgery. Wide local means that you remove the abnormal tissue with a bit of healthy tissue to ensure that no abnormal tissue is left behind. And it's useful, or at least most useful, for unifocal tumors that are less than 5 millimeters. And when the margins are positive, you have the option of going back to re-excise at least twice. After that, unfortunately, you may have to do a mastectomy to ensure you don't leave any cancer behind. And then modified radical mastectomy, that goes all the way to the pectoralis fascia to remove the breast. I must say that a well conducted wide local excision would also go all the way to the pectoralis fascia to ensure that all of the tissue around the cancer is removed. Modified vertical mastectomy is mostly used for tumors that are more than 50 millimeters, even after neoadjuvant chemotherapy, for multicentric tumors, obviously, because by the time you are able to remove the tumor from all the segments, that there will be no breast left behind. And when you've done multiple re-excisions after a wide local excision. And then also when the cancer recurs after you've had breast conserving surgery, you may have to do a mastectomy. Management of the axilla changed quite a bit. We've moved from doing level 2 lymph node dissection to now doing what we call sentinel lymph node biopsy. It's useful for axillae that clinically and radiologically do not have any lymph nodes. What you do is that you inject a dye or a radioactive substance, or the two, close to or into the tumor. And then the lymphatic drainage would pick up this dye or radioactive substance right into the first group of lymph nodes, the first echelon of nodes that drain the cancer. Once you examine those lymph nodes and they show no evidence of metastasis, then likely there are no other lymph nodes that are involved by tumor. Or even if you have a few of them, 2 to 3, there's a lot of evidence from the Amaros trial and the APOSOG 0011 trial that shows that once you've done the sentinel lymph node biopsy and have taken between 3 to 5 lymph nodes, you don't have to go on to do further lymph node dissection. With effective systemic therapy and radiotherapy, these patients do as well as those who go on to have completion axillary nodal dissection. And then there's the typical level 2 axillary dissection, where you have patients who had positive axilla previously, or those who don't respond to chemotherapy. There's a lot that's going on about whether or not patients who respond in the axilla after neoadjuvant chemotherapy require complete level 2 axillary dissection. That's being investigated in several trials. And there's a look at doing targeted dissection, where before treatment, you actually put in a marker, give the chemotherapy, and at surgery, actually look for those marked lymph nodes and take them out, so that if there's complete response in those lymph nodes, most likely there will be no other lymph nodes that are involved. So this image just shows you how the sentinel lymph node biopsy is done. There's the injection of the dye or radioactive substance, and then the lymph nodes are removed. They are removed because you can identify them as being stained by the dye, or if you use a Geiger Muller counter, the radioactive substance would cause it to be. Breast reconstruction has been a game changer. No woman wants to hear that I'm going to lose my breast. And so for the patients who need mastectomy, if you tell them that reconstruction is available, they are more likely to receive the treatment, even if they cannot afford the reconstruction at the end of the day. So please tell your patients about that. It can be immediate. We do that especially for the early stage disease or delayed. So after you've completed your treatment, you can then go on to have your reconstruction. And they can use prosthesis or they can use autologous tissue. So they do tram, latissimus dorsi flap, etc., to try and reconstruct the breast. And they are an important part of our MDTs in Korle Bu. So this is a young girl who had right breast CA. She had a reconstruction done, as you can see. They actually did a reduction of the contralateral breast, and then the reconstruction has been done. Systemic therapy for breast cancer has evolved quite a bit. We've gone from using chemotherapy. In fact, we've gone from doing oophorectomies, and this was identified in the 1800s by Beatson an English surgeon who found that once you remove the ovaries, breast cancer seemed to regress, all the way to World War I, the identification of nitrogen mustard, to developing specific hormonal therapy. Now we have a lot of targeted therapies and immunotherapy as well. And their benefits are well documented and they are rigorously tested. So if your patient comes to you and asks you if they need systemic therapy, and they do need it, please tell them that there's evidence for benefit. These systemic therapies are used in the curative setting, but also in the palliative setting. In curative setting, you can give it before surgery, so in the neoadjuvant setting. And it's useful, neoadjuvant systemic therapy is useful because there's actually in vivo efficacy assessment. The tumor is there, you give the treatment, you can assess it's reducing in size, it's not. So you can intervene. So you have tailored intervention for non-responders. It also facilitates surgery and resectability. You know the numerous cases you've seen who have unresectable breast cancer, you give chemo, it becomes resectable, or even people who have resectable tumor, but whose breasts are so small that a wide local excision is tantamount to a mastectomy. Giving chemotherapy to reduce the cancer would then allow them to have wide local excision, so it facilitates the surgery. And then theoretically, when you give the chemotherapy early, because it's systemic, pardon me, when you give the systemic therapy early, because it goes throughout the body and it's systemic, you're able to control micrometastasis early when they are small and are more likely to respond to chemotherapy. And then these days, achieving pathological response is awfully important, because we know that the patients who are able to achieve pathological response are going to do well in terms of survival, but also that those who do not achieve pathological response can benefit from other treatments, which you cannot get if you did adjuvant treatment. Now, adjuvant systemic treatment is given after you've done your surgery, but you don't have the luxury of in vivo assessment, and your patients cannot get tailored treatment for those who do not respond to your treatment. I want to say, however, that there's no difference in terms of benefits, whether you give your chemotherapy in the neoadjuvant setting or in the adjuvant setting. And like I said, systemic therapy can also be given in the palliative setting to improve symptoms and for prolongation of life. When it comes to chemotherapy, they are cytotoxic drugs that destroy rapidly dividing cells. Unfortunately, majority of the chemotherapy agents are not selective. So once you are rapidly dividing, unfortunately, you become collateral damage. And it's the reason why there's alopecia, nausea and vomiting, bone marrow suppression when you give chemotherapy. Now, there are various classes. Some of them are cell cycle specific, some of them are not. Some of them interfere with microtubules, some of them interfere with checkpoints, for example. So there are different types. Some of them are antibiotics. So there are different types. And the different types have different side effects. And these side effects may be peculiar to specific chemotherapy agents, and we should know that. Adriamycin is associated with cardiotoxicity, which is not reversible. Paclitaxel will likely cause paresthesia, as would trastuzumab. You should know them so that you can help your patients when they come to you with these side effects. And the other thing about the cytotoxic agents is that often they are given as combinations. And the reason is that by combining drugs, especially those that don't have overlapping side effects, you are able to get combined benefits so that the benefit is synergistic. Imagine that you give a cell cycle dependent chemotherapy agent that will push the cell into one stage of the cell cycle. Then you give another agent that is probably microtubule inhibitor. By targeting the different sites, there's a synergistic kill of your tumor cells, and that's what you want. And you must always remember to choose drugs that do not have overlapping side effects. So you cannot combine adriamycin, which is cardiotoxic, with trastuzumab, which is also cardiotoxic, for example. And when you are giving chemotherapy, your patients require follow-up. Follow-up for response to treatment, follow-up for side effects. And I will talk about the advancements in chemotherapy as well, which is our antibody drug conjugates. This is one of my favorite pictures or graphs that shows how efficacious chemotherapy has become. We started with CMF, and as you can see, with the introduction of Adriamycin, we got nearly 4% benefit at 5 years, which is maintained to 10 years. The addition of taxanes to anthracyclines gave us an additional almost 5% at 5% absolute benefit at 5 years. And that's a big deal. So if you didn't give chemotherapy at all, it's worse than if you gave CMF. And if you gave CMF only, it's worse than if you gave Adriamycin. And if you gave Adriamycin only, it's worse than if you gave taxanes. That's why it's not okay to sit by yourself somewhere and continue to give patients CAF when we have evidence that you need to do combination treatment and additional treatment. Hormonal therapy is the oldest treatment for breast cancer, and that was the initial target. There are several classes. They can be used in the neoadjuvant and adjuvant setting. In fact, there are recent trials that have looked at the use of neoadjuvant hormonal therapy in menopausal women. The aim is to see if there'll be a change in the proliferative index. And if there is, those patients are likely to respond to hormonal therapy. And so they may have only hormonal therapy as their adjuvant treatment. But they are commonly used in the adjuvant setting. Once you've done your surgery, done your other systemic therapy, radiotherapy, you may be put on hormonal therapy for 5 to 10 years. And these are, it's based on risk factors. So certain patients are okay with 5 years, some may have 7 years, and some may actually have 10 years. And the evidence suggests that longer duration, especially for cancers that have bad features, are better. And there are various types. There's the selective estrogen receptor modulators like tamoxifen and valoxifene. There's the selective estrogen receptor degraders like fulvestrant, which has been around for a long time, but it's an injection. If you don't like injections, it's not something you might like because it's intramuscular. But these days, there's the tablet elacestrant, which is also a SERD, and it's seen a lot of use in breast cancer care. And then there's aromatase inhibitors, a non-steroidal letrozole and anastrozole. Everybody who's done surgery in Ghana knows about AIs. And then there's the steroidal one, which is the exemestane, not too commonly used, but it's very effective as well. And then these days, there's the CDK4/6 inhibitors, which are used especially in metastatic disease, but has also found use in early stage disease. So the Monarch E trial, for example, saw that for patients who have hormone receptor positive breast cancers, but have more high risk features, so tumors larger than 3 cm, lymph node involvement, grade 3, etc. If you give adjuvant CDK4/6 like abemaciclib and ribociclib, we have evidence for these two that it will result in improved invasive disease-free survival and even overall survival. Now, I want us to discuss targeted therapy quickly. And targeted therapy has become useful as we've understood the hallmarks of cancer. So as you can see from this image, the various hallmarks are being targeted. And the benefit of this is that the side effects profile are fewer. I say fewer in quotes, but more importantly, they are different from your typical cytotoxic therapy. Now, some of the targeted therapies that I'm sure we all are aware of are the monoclonal antibodies like trastuzumab that targets HER2, pertuzumab that also targets HER2 and HER3, or the combination drug called Phesgo. And then there are also the HER2 targeted tyrosine kinase inhibitors, often given either in the metastatic setting or in the adjuvant setting, especially for patients who for some reason did not receive trastuzumab or who receive trastuzumab, but you still think they're at increased risk. And these include lapatinib, neratinib, and tucatinib. Like I mentioned, antibody drug conjugates are the new kids on the block. They are everywhere. And it combines antibodies, cytotoxic drugs together via a link. Now, what's special about antibody drug conjugates is that the antibodies will bind to a specific antigen that is overexpressed in the cancer cells. A few of the ones that have been used are HER2. There's also the trophoblast cell surface antigen, TROP2. Now, these antigens are targeted using antibodies. And then in combination with these antibodies are chemotherapy agents, which are described as the payload. I hear people don't like payload because it connotes war. But really, that's about how it's like. It's a payload. Once the antibody binds to the antigen, the payload complex is internalized. And then lysosomes are activated. The linkage between the two is cleaved, and the cytotoxic drug becomes available within the cell. It destroys the cells that have the antigen because those are the ones internalized. But even more importantly, there's the bystander effect, where cells that do not even express those antigens are killed as well because of the internalization of the antibody drug conjugates. And there are so many of them currently. There's trastuzumab emtansine. It's been investigated in metastatic disease via the Emilia trial. And then as adjuvant treatment for patients who do not have complete response to trastuzumab or trastuzumab-pertuzumab combination in the Catherine trial. There's also trastuzumab deruxtecan, which is a combination of trastuzumab and a microtubule inhibitor. And it's been investigated in the DESTINY trials, has been shown to be effective in HER2-positive breast cancer, but also in what is now described as HER2-low breast cancers. So you remember typically, if a patient had HER2 3+, they are HER2-positive. Well, there are those who are 2+ and 1+. And if you do FISH stain and they don't turn out to be HER2 enriched, these cancers would respond to trastuzumab deruxtecan and are currently being used effectively in the treatment of breast cancer. And then there's the sacituzumab govitecan. This one combines the TROP2 with a topoisomerase inhibitor, and it's useful for treating triple-negative breast cancer and the luminal breast cancers that are HER2 negative. The same is true for that, read the name. It's also a TROP2 inhibitor combined to a topoisomerase inhibitor. And this has been investigated in the TROPION trials and seems to have survival advantage for hormone receptor positive HER2 negative breast cancer. Immunotherapy is here to stay. Usually, our bodies do not recognize cancer cells as foreign. And this is because cancer cells produce the programmed cell death ligand in large quantities. So T cells have the programmed cell death receptor, which ordinarily binds to PD-1 ligands and to identify cells. Now, cancer cells produce a lot of that, and so your T cells do not recognize your cancer cells as foreign, and so they evade immune destruction. Current therapies have looked at inhibitors of not only the receptor, which is the programmed cell death receptor, but also the ligand, so that with the absence of the ligand binding to the receptor, cancer cells are actually recognized as abnormal cells and are not able to evade immune detection. There are so many types that are in use currently. There's the PD inhibitors, so the ones that block the receptor themselves, pembrolizumab, nivolumab, but also ones that inhibit the ligand, the PD-L1 inhibitors, such as atezolizumab, avelumab, and durvalumab. Radiotherapy is the third important arm for treating cancer of the breast. It uses megavoltage radiation to destroy the cancer cells. And it's not only useful for controlling the local disease, it's also very useful for improving overall survival. There's a lot of evidence for this. The Early Breast Cancer Trialist Group have shown close to 30% survival benefits for the use of radiotherapy, depending on the stage of cancer that you have, especially whether or not you have nodal disease. And so it's an important part of treating breast cancer. In fact, the evidence shows that 70% of the patients who are diagnosed with cancer will require radiotherapy during some part of their treatment journey. It's a must when you do a wide local excision. Wide local excision plus radiotherapy is what combines to become the breast conserving therapy. And then we use it as well for those with advanced disease after modified radical mastectomy. Often it's given in the adjuvant setting. So whether you give your chemotherapy or not, you do your surgery and we give radiotherapy in the adjuvant setting. But there's a lot of trials that are being conducted currently that looks at neoadjuvant radiotherapy. In fact, concurrent chemoradiotherapy, especially for the cancers that do not respond well to systemic therapy. This may be used to try and make the cancer resectable, and then you can go on to do surgery. Every tumor that is more than 50 millimeters should receive radiotherapy as part of their treatment. And it's not only given to the local site, so not just the residual breast or the chest wall, but we also do regional nodal irradiation. So we may give radiotherapy to the axilla, to the internal mammary, to the supraclav nodes as well. Our therapy machines have evolved a lot. We've gone through machines that give so much dose to the skin that by the time you are done, the skin is burning. That's where burning your cancer came from. To the use of cobalt-60 machine, which is not as deeply penetrating as the linear accelerators, which are the new equipments that are in use. The linear accelerators have different energies that allow for the radiation therapy to be deposited deeply into the body while sparing the skin and the organs on top of it. And these days, we also have improved delivery techniques that ensure that high doses are delivered to the tumor, and especially to the center of the tumor, where oxygenation is low, and so tumor death is lower. And then it also reduces the dose to your organs at risk. So we delineate the cancer, but we also delineate the organs at risk and ensure that the dose to those organs at risk are kept to the minimum so that side effects are much, much lower. The delivery techniques, there's 2D, we still use it, but not as much. There's 3D conformal radiotherapy, which is the commonest used one these days. And there are others. There's 4-dimensional radiotherapy, where the radiotherapy is adapted to your respiration, or the patients are taught to do what they call deep inspirational breath holding to ensure that the radiotherapy is delivered at a time when the heart is far away from the chest wall, for example. There's also intensity modulated radiotherapy, where the doses are modulated to ensure that the sites that require a lot more radiation receive that while reducing the dose to the surrounding structures.
Dr. Isaac,
that is also very useful for palliation, pain control.
Five more minutes, please.
Pain control, improvement of neurological symptoms, especially from cord compression. It's useful for controlling bleeding and ulcers. For patients with brain metastasis, it would control intracranial pressures. And then, like I said, when it's used in the neoadjuvant setting, it will improve with resectability. There are various gaps, and I think as clinicians, there's something we can do to bridge that gap. One is that it's important that breast cancer is diagnosed early. Once it's diagnosed early, therapy is less intensive, outcomes are better. Let's not put breast cancer as our last differential. Education is important. The general public, healthcare workers, it's the only way the differential diagnosis of breast cancer will come to the forefront. We should encourage our patients to do the self-breast examination. In poor resource settings, it's been found to be very useful in identifying the disease earlier than if they weren't doing self-breast examination at all. Education like this is important. As family health physicians, most of our patients will come to you. A lot of women will come to you multiple times within a year. Please make use of their presence in the hospital to examine them clinically, but also to offer them screening mammography. Multidisciplinary approach is important. As you've seen, there are different modalities that are applied in different ways. And then multidisciplinary team approach will allow you to give a good plan for a patient, which is personalized and precise. We need to open up referral channels. Even if the system hasn't done its job, give your colleague a call. That might make a difference for a patient. We need to train more specialists. We need to build more cancer treatment facilities. And we need to engage our competitors, the herbalists, the spiritualists, as our patients are very likely to go to them. So once they are our collaborators, then we are able to give the best to our patients. Thank you.
Thank you very much, Dr. Na Adoko Ayite. I'm sure you may have a number of questions. Please use the Q&A segment to put in your questions, and we'll take them after we've heard the second speaker. Thank you very much again, Dr. Na Adoko Ayite. The second speaker will be Dr. Gordon Amoh, and he'll be speaking on family medicine tools in breast cancer care. The session will focus on how family medicine tools can be effectively applied to support patients and families navigating a breast cancer diagnosis. Dr. Amoh will also discuss practical tools such as the genogram for family history assessments, family conferences for shared decision-making, and the SPIKES, S-P-I-K-E-S, protocol for breaking bad news. It will also emphasize a person-centered, holistic approach that integrates psychosocial, spiritual, and family dynamics into cancer care. Dr. Gordon Amoh is a senior specialist family physician in the Department of Family Medicine, Korle Bu Teaching Hospital, where he also serves as the training and research coordinator. He holds an MPCHB from the University of Ghana Medical School and a Master of Public Health from the University of Edinburgh, which he completed through the prestigious Chevening Scholarship. He's a fellow of the Ghana College of the Physicians and Surgeons in the Faculty of Family Medicine. With a strong foundation in both clinical practice and public health, Dr. Amoh's research interests include primary care, person-centered care, non-communicable diseases, and vaccines. And his work reflects a deep commitment to strengthening primary care health systems through innovation and evidence-based practice. He currently serves as a project consultant for the Bisayen Breast Cancer Project, which we've heard about, and is also the acting executive director of the Global Outreach Consortium. That's the NGO spearheading the Bisayen initiative. He brings a unique perspective on integrating family medicine tools in breast cancer care to improve outcomes for patients and their families. So join me in welcoming Dr. Gordon Amoh, who now speaks on the topic, family medicine tools in breast cancer care. Over to you, Dr. Gordon Amoh. Gordon, you are muted at the moment. All right. Whilst we are waiting for him, we'll answer one or two questions in the interim. So these questions, therefore, are going straight to Dr. Nada Kwaite. The first one says, thank you for the insightful presentation. I have a question which says, I once had a 23-year-old lady who had been visiting the hospital for about 2 years before I met her. Her auntie did not survive breast cancer, and her complaint was recurrent pain in the breast, bilaterally. Breast ultrasounds were normal, and we repeated it, and it was also normal. For such cases, please, what do you suggest to help ease the anxiety? Thank you. So there's somebody with bilateral breast pain, normal scans.
Hello.
Yes, now.
Yeah, I hope you can hear me. So
Yes.
I'll just say that I can understand her anxiety. However, as you well know, often breast cancer is not painful. There are a few instances when it can be painful. However, for majority of the cases, it's not. And if your ultrasound scans in a 20-something-year-old are normal, maybe there's nothing to be worried about. Just encourage her to continue to examine herself and to do the ultrasound scans based on what you think is required. But you can give them some analgesics, whether topical or oral. Usually the NSAIDs will work. And then there's also, I think, vitamin E capsules and evening primrose that may be useful. If she has a very strong history of breast cancer, I don't know if it's just her auntie, but if there are others, then maybe you should get her to do the assessment for genetic testing. If she's at risk, then maybe she can do the BRCA or leave-for-many test. Apart from that, really, it's just encouraging her and telling her she's doing the right thing by being interested in her breast. That's all I think you can do for now.
Let's take a quick second question. So this one says patients who have breast cancer but do not have money for chemotherapy or the surgery, what is the alternative management option?
Are you a doctor in Ghana as well? Yeah, the alternative for a typical Ghanaian doctor is to help raise funds for the patient. But if you're a politician, then you would say that there's some talk about the Mahama Cares that is supposed to come and bridge the gap between the NHIS and the current status quo of paying out of pocket. I don't have all the details with it, but the details of it. But I hope that it would be a good bridge. The other thing is that the surgeons and the oncologists, they have ways, believe me, and whether it's to describe the lesion as a tumor so that it will be covered by health insurance, there are ways. So please reach out to your surgeons and oncologists, and they may be able to help. And always remember that there are some support groups that actually pay for treatment of patients. Run for a Cure Ghana, a few others. So you can look for them as well to help your patients.
Okay, let's take one more. So this is from Dr. Nabake. She says she has met a few patients who have had wide local excision and interprets that to mean complete care, complete cure, and they decline radiotherapy. And she has also met some ladies who think that breast cancer can be cured by surgery alone. It says from your lecture, you said radiotherapy should follow wide local excision. How do we explain this to them?
It's very difficult to explain, especially when a lot of it is statistics and a lot of graphs. But I think it's important that right at the time when you are counseling them for the type of surgery you want to give them, you must explain to them that breast conserving therapy is a composite, that surgery, the type of surgery they choose must necessarily come with radiotherapy. And maybe show them evidence of recurrence, whether it's from pictures or videos, whatever. I think that might be the way to go. But honestly, I think that if the counseling goes well initially, they are likely to go on with the treatments that you ask them to receive. There are a few people who will decline it. There's really not too much you can do about it. Use your psychologist. They have a special way of getting them to agree to the treatment. Use your survivors. They are even more special in getting the patients to do what, as a doctor, you spend years to encourage them to do. So those are my tips.
Right. Thank you very much. I think Dr. Gordon is ready now. He had an unstable network. So if you're ready to go, Gordon, over to you.
Yes, thank you very much, Prof. And my sincere apologies for the technical hitches. And I believe Dr. Abena will share the slides for me and then I can present it from my phone. All right, so we are going to talk about family medicine tools in breast cancer care. And we all know that when it comes to current practice of medicine, we've moved away from the paternalistic, kind of care to a more patient-centered, kind of care. And the Institute of Medicine defines patient-centered care as providing care that is respectful of and responsive to individual patient preferences, their needs and values. And when we compare the biomedical model of care and the biopsychosocial approach to care, which is actually the preferred, kind of care, you realize that the biomedical model of care leaves no room within that particular framework for the social, psychological, and behavioral dimensions of ill health. And therefore, in as much as we are interested in making the right diagnosis of breast cancer, we are also equally interested in the illness experience of the patient. Next slide, please. Next. Yes, you can move to the next slide. Yeah, move to the next slide. Yeah, so the previous slide, please. So when we talk about the family medicine tools, we cannot talk about the family medicine tools without the mention of what has been described as the FIFE concept. And the FIFE concept, the FIFE is actually an acronym that stands for the feelings, ideas, function, and expectations. And when we compare disease to illness, we know that when we talk about disease, we are looking at a theoretical construct by which clinicians explain patients' problems in terms of the abnormalities of structure and then functions of body organs. But then when we talk about the illness experience of the patient, we are looking at the patient's perspective of the ill health. And over here, the focus is on the feelings that they have regarding a particular illness condition, especially the fears that they have. So in this context of breast cancer, we want to explore the fears they have or the feelings they have about the breast cancer, the ideas that they have about what is wrong with them, and then also how this breast cancer has impacted their function. So in terms of occupation, in terms of the things that they're able to do and all of that. So these are the things that we are interested in. Then we are also interested in the expectations. So as they come to see us in the various health facilities, you want to find out what do they expect from that particular encounter. Next slide. Yes, so that brings us to the 3-stage assessment, where yes, we make a diagnosis of breast cancer, which is the biomedical diagnosis. But then if we leave the diagnosis at just the clinical diagnosis, then it means that we are just looking at the biomedical or the doctor-centered or clinician-centered diagnosis, which is not enough. So we need to go ahead to make a diagnosis. That is the individual diagnosis and the contextual diagnosis. And the individual diagnosis is what you get, the diagnosis that you make from the patient's illness experience. So that is where the FIFE comes in. Next slide, please. Yes, so let's look at this clinical vignette, looking at the 3-stage assessment. So we have a 46-year-old woman who presented with breast lumps to the hospital, and this was confirmed to be malignant. She was informed that she needed surgery and chemotherapy as part of her treatment. Patient wants to be cured from the breast cancer. She fears that both of her breasts will be cut off, and this will affect her femininity, just like Na mentioned in her presentation about the fact that having the breast cut off is really a big deal when it comes to women. Also, she has read on the internet of some side effects of chemotherapy and is worried. She believes there is a spiritual cause to her diagnosis and she will die soon. The diagnosis of breast cancer has negatively impacted her output as a teacher, and she admits to financial challenges in being able to fund her treatment. Next slide. So with this clinical vignette, you can look at it in terms of the FIFE, trying to explore her feelings and her fears. And then the fear is fear of losing her femininity after surgery, concerns about chemotherapy side effects, and then fear of death. Then what are her ideas about the breast cancer? She thinks that there is a spiritual cause of the breast cancer. And then in terms of functioning, her performance has been suboptimal. And then expectation is she's expecting a cure. Next slide. So when we look at the 3-stage diagnosis, you can see that, yes, we have a diagnosis of breast cancer where treatment is available, recommended by oncologists, surgeons, that is surgery, chemotherapy, radiotherapy, and then all the other options that Na just mentioned in her lecture. But then we need to also look at the individual diagnosis and try and address those particular concerns. The concern that of she losing her femininity, the concerns about chemotherapy, the attribution to of the breast cancer to a spiritual cause, and the fact that she wants a cure. This is where we need to really discuss dispassionately with the patient, let the patient understand everything about breast cancer, the treatment options, and then try to provide her the needed support. And if this is done very well, then we are not likely to have the patient falling through the cracks and being lost to follow-up. But oftentimes, we don't pay too much attention in this area, and then the patient will then look for other options and then will be lost to follow-up. So this is the essence of having this three-tier diagnosis, where we look at both the clinical diagnosis and then address them, individual diagnosis, address it, and then the contextual diagnosis. So for example, the issue of the financial challenges. This is a patient who has financial challenges, and it's just a matter of time that she will be lost to follow up. And it's incumbent on us as healthcare professionals to go the extra mile, identify support systems that are available, involve family, involve other organizations to help her to be able to go through the breast cancer treatment. Next. So the other tool that we can look at is the family genogram. And the family genogram has been described as a representation of at least three generations in a family. And oftentimes people misconstrue a family tree to be the family genogram, whereas family tree basically looks at the family and the lineage. A genogram goes ahead to give us a record of the family structure, how it is organized, the relationship patterns that exist in a family. And it's a very important tool that we can use as clinicians to gather information from the patient in a very systematic manner, and also in the context of their family and then also their relationships. And I must say that genograms have been used in other jurisdictions aside family medicine, in psychiatry, psychology, social work, genetic research. Family genograms have been used. And it's as I've mentioned already, it provides the family structure and then also relationship patterns and then also patterns of illness. Next slide. So oftentimes the genogram can be the first tool that will help you to really establish rapport with your patients. And in doing your assessments, you try to find the interactions in the family. You try to use various symbols to depict the individuals and the relationships in the family. So issues of gender, whether the person is married, diseases that exist in the family, the kind of relationship, whether the relationship is good, whether there are conflicts, all of these things can be depicted in the genogram. And it provides a very important resource for the clinician, and also helps in terms of continuity of care, because once one clinician has documented the patient's genogram very well, another clinician can look at it and provide so much information for that clinician. Next slide. Next slide. Yeah, so this slide basically gives us some of the conventions that are used. So typically a male will be put at the left side and then the female on the right side. You use a line to connect a male and a female to depict marriage, and then you use a vertical line from that connecting line to depict children. And then you have various symbols that are also used to depict marriage, to depict whether, for example, there is a divorce, whether there is death, and all of that. So there are various symbols that are used, so many of them, and usually one is not required to necessarily memorize all of this. So the various symbols are helpful in terms of depicting the information that we want to connote. Next slide. So this slide basically also gives us further information in terms of the information that goes into the family genogram. So the index patients usually will have a double line around it. So a male is a square, so you have a double line around it. A female is a circle, you have a double line around it. And then also you can write a date of birth, either, for example, if it's 1961, you can write, if you know it, you can put it there. And then we use a cross within the circle or within the square to depict death. And then also if there is pregnancy, if there is stillbirth, if there is adoption, all of these things can be depicted and in the genogram. Then you can also have relationships. So if you look at right lower side of the slide of the picture, you can see different relationships. So very close relationship, you have 3 lines. That means that the relationship between those 2 individuals are very close, very strong. And then if you have double line, it means close relationship. If you have this kind of zigzag line connecting the 2, it means that there is a conflict in that family. And all of these things provide very important information that the healthcare provider can utilize. Next slide. Yes, so the genogram can be used as a preventive tool and also therapeutic tool. We've already mentioned that it can be the first tool that you use to really establish rapport with the patient and leverage on that to provide whatever treatments you want to give to the patient. But importantly, especially in the context of breast cancer, it can be a very good preventive tool in the sense that once you see certain patterns in the family, for example, a patient comes to see you, the mother had breast cancer, the auntie had breast cancer, automatically your alarm bells, begin to ring, and that may be the opportunity to advise the client to do some form of targeted screening, and that can be a way of detecting breast cancer early, and then also a way of preventing it. Next slide. In terms of the components of the genogram, usually you want to have a title, you want to have a date, the symbols that are used, you want to use very simple tools, symbols. At least 3 generations should be represented. And by 3 generations, what we mean is, so for example, if you are seeing the patient and the patient can give you information regarding the parents and the grandparents. So that will represent an example of 3 generations. And then you have the ages and then the occupations and then significant diseases that run in the family. And any form of cancers will also be an important information to elicit from the patient. Next slide. So deaths are also recorded, date of marriages, indications, of members living together are all documented. And then importantly, the keys or the symbols that you use, you need to have a legend or a key that will be able to explain this so that anybody who looks at it will be able to make the necessary information, get the necessary information from this genogram. Next slide. So this is an example of how a genogram can look like. And you can see from this slide, the index patient is a female, that's Ms. VF. And then you can see that Ms. VF's mom is dead because you can see just on top of that, there is a cross that's within that circle. And the information that we've been given the date that she died, and then the fact that she died from cancer of the breast. And then also there are other information that is available. So this is an example of a genogram, a very simple, tool, but then connotes or gives so much information to the clinician, and that can be used. But then importantly, as I mentioned, information that you get from this can prompt early screening, can promote early detection, and then also can lead to some form of family-wide risk education. Next slide. So now that takes us to another family medicine tool that is also very useful in terms of breast cancer care. As healthcare professionals, we often find ourselves in situations where we need to convey difficult news to patients and also to relations. And in as much as bad news is never easy to hear, when you get somebody who delivers the news very well, it can make the person who is receiving it feel respected and also feel supported, going forward. And one of the tools that it can be used to break bad news is the SPIKES protocol. And the objectives of using this SPIKES protocol are to gather information from the patient and also be able to relay important medical information to the patient, provide support to the patient, and then also get some collaboration from the patient in terms of the way forward for that particular patient. And the SPIKES is a very effective way to really structure, the breaking of the bad news. Next slide. So the SPIKES stands for, it's an acronym. So the first S is for the setting, and it's important to break the bad news in an appropriate setting. So you need to make sure that there is enough privacy, and then also if the patient will want you to involve some significant others, and you need to involve them. The discussion should occur in a very comfortable, quiet, and private room. And in as much as we know that this is not always possible, we need to at least make sure that there is some privacy. It is not right to break bad news, for example, standing in a corridor. That is not right. At least the patient and the clinician should both, find a comfortable place to sit. And there should also be, connection and establish rapport with the patient. This is also a time that, as much as possible, the clinician will want to make sure that his or her phone is off, there are minimal disturbances and all of that. You don't want any disruption or interruption at the time that you are communicating such a vital, information to your patients. So you want to avoid, physical barriers and ensure that you give the patient the undivided attention. It is possible that you may need other people to be in the room, but of course, that will have to come with the consent of your patient. Then there's P is the perception of condition or the seriousness of the condition. So you want to begin by discussing the sequence of events leading to, where you are. So for example, you saw the patient, you had, ultrasound scan done, you had mammogram done, you had CT scan done, the patient did some biopsies and all of that. So it is important to have a sequence of events and assess the patient's current, emotional state as well. You can decide to ask about any symptoms the patient may have been experiencing up to the point, just to, let the patient relax and then gradually take the patient to where you want to deliver the information. You could also, for example, agree with the patients and say something like, yes, the reason we wanted to do this test were so we could find out what you've been experiencing in terms of the symptoms you described to me. And then maybe you can ask a question, were you aware of what sort of things the investigations might show? So all of these things will sort of prepare the patient's mind, help you to have a dialogue with the patient, and then gradually get to the point. And you need to also listen to the patient's level of comprehension. So it's not a one-way communication. Allow the patient to also be able to contribute. And we should also know that it is possible that patient may be in denial at this stage. And as much as possible, you don't want to be confrontational at this stage when a patient is in denial. So that is what the perception stage seeks to address. We want to find out what the patient knows and then get the understanding of what exactly is happening. Next slide. Then we come to the I, which is the invitation from the patient to give information. So at this point, you want to check if the patient wants to receive the results today. It is possible the patient may tell you, I'm not ready to receive this information. So if that is the case, then it has to be postponed. So you want to know how much the patient also wants to know in terms of the details. And you need to respect the patient's, decision at this point. You want to answer any questions that the patient may have. And we go to the next one, that is the K, knowledge. So at this point, you want to ensure that you deliver the information in very sizable chunks, and then also whilst regularly checking the understanding of the patient. And this is where usually we refer to what is commonly called a warning shot to indicate that you have unfortunate news for the patient. So you can say something like, as you know, we took a biopsy or we did a scan, and unfortunately the results were not as we expected. And once you say that, you need to pause a little bit. And this pause is very important because it helps the patient to really digest what you have just told them. And then you provide a diagnosis using very, simple language. You don't want to be technical in terms of your choice of, words. So, for example, I'm sorry to tell you this, but the results from the investigation shows you have cancer. So it's important to use the correct language. Cancer is cancer and death is death. And there is no need to be, ambiguous about this. The last thing that you want to happen is for the patient to leave with a different understanding of what information you are trying to communicate. So you want to avoid, medical jargons and the use of euphemisms. So as I've mentioned earlier, you want to deliver the information in chunks. You pause in between each piece of information. And then after you've given the diagnosis, it's also wise for the patient to sort of reinitiate the conversation. And whilst doing all of this, the tone must be very respectful and you shouldn't be rushed. You shouldn't rush the patient. You must do that in a very slow pace and you must be very clear. And it is also possible that, very likely that, the diagnosis of cancer evokes a lot of emotion, and therefore your patient may exhibit some form of emotional reaction. The patient may be crying or maybe may become hysterical or angry, and you should be prepared for that. But as much as possible, you need to give the patient time for that emotional reaction. And people often find it very uncomfortable watching patients like this. But as much as possible, as clinicians, it's important that we give the patients, space to react. If you have you need to have probably some tissues around. And if the patient is, for example, shedding tears or crying, you offer tissues to the patient. Next slide. All right, so the E is exploring emotions, and then empathy. So you, at this point, will want to recognize and respond to the emotions, and then you don't want to lie when the patient asks questions about prognosis. So you don't want to give any false hope. If you do not know the information, you want to admit to the patient that you do not know the information, and then suggest that you can refer them to a specialist or someone else who has the information. Give the patients time to really express their feelings, and then let them express their feelings. Yes. So the next stage is the S, which is strategy and summary. So you have broken the news to the patient. What's next? What is the plan? And this is where you need to come in. You need to reassure the patient, letting them know what is going to be done, who they are going to be referred to, what kind of follow-up arrangements need to be done. And once again, you don't want to rush the patient. You want to check the understanding of the bad news that you have delivered, and then you have to summarize. So every breaking of bad news needs to end with a summary where you respectfully and gently repeat some of the very important points that you have already provided to the patient, and also answer questions that they may have. And at this point, if you have some written materials that you think will be beneficial to the patient, it will be good to offer it to the patient at this stage. Next slide. So there are other protocols for breaking bad news. When you look at literature, you realize that there is the BRICS protocol, which is often used in palliative care and oncology settings. You have the ABCDE protocol, which focuses on patient-centered communication. And they also have the COMFORT model, which also use a lot in palliative. But then the important thing is that all these protocols, including the SPIKES protocol, they all have certain key principles in common. And that is the fact that you need to prepare thoroughly as a clinician in breaking bad news. That is, you need to know the facts and the, of the case very well. And then the fact that you need to be honest, you need to be compassionate, and you also need to tailor the conversation to the preferences of the patient, allow the patient time, as we've already talked about, and then also follow up with emotional support. So irrespective of which protocol you want to use, largely they all sort of talk largely about the same thing. Next slide. Next slide. Hello. Next slide.
Should I move on to the next slide, please?
The next family medicine tool is the family circle. A circle that shows the emotional relationships of a family in the eyes of the patient. So this is what the patient feels. And the distance between people in the circle reflects the level or the degree of emotional attachment or closeness that they have with that individual, and basically gives you an idea of the dynamics in that family. Next slide. So the family circle is drawn by the patients. So the clinician will give the patients directions, and the patient will actually draw it. And then it's a very important tool that is very useful in terms of setting goals of change in the family system. Next slide. So there are times that a patient may tell you they cannot draw a family circle. As much as possible, you want to give them direction and guide them to be able to draw it, but the clinician should not draw it. And the patient or the index patient you are seeing is put at the center of the circle. So you draw a big circle and then you put the patient at the center of the circle. Then the patient is asked to look at the family and then put other members close to him or her, depending on how close they are. So for example, if they are very, very close with a particular person in the family, that person will be very close to them in the circle. If they are not too close with another person, that person will be farther away from the index patient. If there are probably conflicts, or the patient doesn't probably have a very good relationship with a particular member of the family, that person probably may be on the edge of the circle or probably even outside the circle. And all of these things gives you an idea. Next slide. It gives you an idea of the closeness of the patients with the other family members. So this is an example of a family circle. So you have a patient at the center, and you can see different people around the patient. So for example, Sam is a son of the patient. You can see that Sam is close to the patient. Also the brother as well. But if you look at, for example, the in-laws the in-laws are on the edge of the circle, and their mother and father are also farther away. So for such a patient, if the patient has breast cancer and you want someone who can really provide, good emotional support for the patient, you will not go for the in-laws. You will not go for the mom or dad. You will have to go for someone like Sam, who is the son or the brother or even the husband, who are much closer to her in a circle. So essentially, this is the essence of allowing the patient to draw a family circle. Very simple tool, but provides very good information that you can use in terms of caring for the patient with breast cancer. Next slide. So the next family medicine tool is what is referred to as the EcoMap or ecological map. So what the EcoMap does is that it gives you an idea of the resources available to the particular patient. So it gives you a visual map of the family's connection to the external world. And at the center of the EcoMap is the client. But then for an EcoMap, it can be a family. The family can be the unit under consideration. And yes, so it can help you to really understand the view of the patient in terms of the people who are available to provide support, the resources that are available to the patient. Next slide. Yes, so the relevant systems are connected either individually to the family, to the individual or to the family. And then we also use lines. We use lines to show the direction and then also the strength of the relationship. So if the lines are thicker, so for example, if the line is drawn from the patient to, let's say, the church, and the line is thicker, it suggests that there is a strong, kind of relationship between the patient and the church. Then we also have arrows. Now the arrows can point away from the client. If the arrows point away from the client, then it means that the client primarily influences that particular system. So for example, this patient and then the church that we've mentioned, if we see that the arrow is pointing towards the patient, it means that the church has more, influences the patient. And this EcoMap gives us an idea of the resources available. So in the context of breast cancer, you are seeing a patient who has breast cancer. And just like the clinical vignette that we talked about when we talked about the genogram, this patient has challenges with financial resources. This is where an EcoMap becomes very important because it gives you an idea of the network. So maybe the patient attends a church. She's a chorister in the church. She is an active member of the church. Maybe in the patient's catchment area community, there is an NGO that probably also supports patients with breast cancer. So by drawing your EcoMap and having an idea of the network available, the people that you can fall onto, the resources that are available for the particular patient. So this slide basically gives us an idea of how an EcoMap looks like with the various connections. In this case, you can see the work, the extended family, the church, NGO, all these institutions or individuals have an influence on the patient, and this is something that we can leverage on in caring for our patients who have breast cancer. And let's look at the next slide, please. Yes, so let's go to the spiritual assessment tools. Yes, so the next family medicine tools that we want to talk about are the spiritual assessment tools. And we define spirituality as the quality of being connected with religion or the human spirit. And this spirituality is very important when it comes to especially breast cancer care. Why am I saying this? Because based on spirituality, it can help us to help the patient to really cope with the diagnosis that has been given to the patient, and also the uncertainty surrounding the cancer diagnosis. We all know that diagnosis of cancer, triggers existential questions and emotional distress on the patient. And spiritual beliefs can offer, meaning, a sense of hope, and also inner strength for the patient. And this can really help the patient in terms of navigating her fear, the grief, and also sense of loss. And there are actually literature that reports that patients who feel spiritually supported often report a better quality of life, even when the cancer diagnosis is advanced. And importantly, the spiritual assessment tools can also help us in terms of guiding our decisions. We all know that spiritual and religious beliefs have an influence on health decisions that patients make.
We have 5 more minutes, please.
Okay, Prof. Decisions that they take in terms of their acceptance, in terms of treatment, in terms of they going for alternative treatments and all of that. Okay, next slide. So there are various family medicine tools in terms of the spiritual assessment tools that can be used. Because of time, we'll probably just look at just one. So one of them is HOPE. So the HOPE stands for, it's an acronym. So the H is for the sources of hope, where you want to find out what are their sources of hope. You want to find out. O is for the organized religion. P is for the personal spirituality. And then E is the effects on medical care, and then also end of life, issues. So there are a set of questions that go with each of these. And by asking these questions, you are able to really, find out how you can leverage on their spirituality to get, good outcomes. And also where there are conflicts, with the spirituality and medical care, that gives you opportunity to sort of resolve it. So, as I mentioned, there are several of them, but we'll just look at just the HOPE. So we can look at the next family medicine next slide. That is a family conference. A family conference is very, very important. Very, very important, because there are times when we see our patients and we need to involve, significant others. We need to get them to the point where they can really appreciate, the kind of diagnosis we are dealing with, the treatment options available, and all of that. And that is where family conference becomes very important. And to do the family conference, there are certain pre-conference tasks that the clinician needs to look at. Next slide. So first of all, you want to, next slide again. You want to choose the contact person. In this case, the patient that you are going to see, or the patient for which the family conference is going to be organized. You need to establish rapport. You need to set the date for the conference, the venue. Do you want it to be done in the hospital, or do you want it to be done at home, and all of that? Next slide. And then you also need to really determine what exactly you are going to talk about. You need to plan all these things, the questions you are going to ask, and then also have in mind that you need to be flexible, because new things may come up even though you have a set of questions in mind. Next slide. Yes, so on the day of the conference, you want to, introduce the topics. You want to let all those present introduce themselves. You talk about the topics for discussion. You allow room for discussions. And then after you are done, you identify resources, and then also the task that has been given. So who is to do what? Who is supposed to probably maybe be in charge of, the purchase of medications? Who is supposed to maybe provide some level of support for the patient that you are seeing? And when all is done, you now have a plan and you conclude. But then, next slide. When you are done with a family conference, you need to really document what has been discussed. And once again, this will be very helpful in terms of continuity of care, and then also in terms of following up to the tasks that was discussed, whether they are being followed or not. Next slide. So the last family medicine tool that probably we'll talk about is the bereavement of care. We know that for cancer patients, in as much as we want a lot of them to recover fully, unfortunately, some we will lose some of them. And it's important to have in mind as clinicians that when the patient dies, that should not be the end. There is something called bereavement care. And this refers to the emotional, psychological, and practical support that is provided to individuals who are grieving. And this may come in the form of appropriate communication in terms of the loss, assisting them to, overcome the loss. And then also, importantly, being able to identify what is abnormal grief. And there are situations where after the patient relations have lost their loved one through breast cancer, they also go through a lot of challenges in terms of even getting the cause of death certificate. And we believe that this should not be the case. As much as possible, if the patient is being managed by the family physician together with maybe oncologists and the surgeons and all of that, and we know that this breast cancer is advanced, as much as possible, there should be even some discussion ahead of time as to how the patient's, death certificate, cause of death certificate is going to be signed, even before the patient even passes. And it's also important, next slide, to mention that there are certain signs that may suggest that one or two, patients that we see, their relations may require some form of extra bereavement support. So, for example, if you find out that the patient's relations are having difficulty in terms of their daily function, they tend to experience intense feelings of guilt or anger, or isolation or withdrawal, or even substance abuse, or there is, some form of prolonged or complicated grief, then this definitely suggests that this crop of patient relations will require some form of extra bereavement support. Having mentioned the prolonged and complicated grief, in terms of the diagnosis, the DSM-5 mentions prolonged grief disorder to be someone who has experienced death of another person, and this has gone on for about 12 months. And then the person exhibits persistent, grief, responses. That includes like intense yearning or longing for the deceased, or if their minds are preoccupied with the deceased. When you see some of these things, then that should alert you that this patient may be experiencing some form of grief disorder. Or some people will tell you that they feel that a part of them is dead, or they still cannot believe that the person is gone, or they want to avoid any form of reminders at all of that the person is gone. So all of these things, when we see these things as clinicians, it should alert us that this patient may need some form of support, and we need to be there to, activate the appropriate, referral processes. Next slide. Next slide. So to conclude, we know that breast cancer is a very common, condition that we see, just like Dr. Ayite mentioned. And these tools that we have just gone through are very simple tools that we can use that can help us to understand the person behind the patient, can help us to improve our communication, and also trust and empathy that we have for the patients. It can help us to strengthen the family support systems, and also guide us in terms of clinical, decisions that we take, so that the decisions that we take will be person-centered and will align with the patient's values and beliefs. So breast cancer doesn't just affect the body. We know that it impacts a story, a family, a faith, and a future. And these tools that we use in family medicine can help us to care for all of this. Thank you very much.
Thank you so very much, Dr. Amu, for this. I think your closing words really summarize, or they do summarize the what it all involves. That it does not just affect a body, it affects a story, a family, a faith, and a future. And it was stressed that we have to move from this biochemical model to a more holistic method. It's a social, spiritual, the whole thing that affects a human being. Right. I don't know how much more time we have for questions. I will let Dr. Sapong read any questions that there may be comments in the Q&A, and then we would maybe I may give a few closing remarks. Dr. Sapong.
Thank you very much, Prof. Clegg-Lamte. I'll zoom into Daniela Santiapia's question. He says, how can we fast-track referral cases? We refer several cases to the breast clinic, but the patients reappear later with complaints that it takes them so long for them to be attended to. Thank you for the presentation. I don't know if Prof will take this or the presenters will do that.
Well, let me try that. Yes, it might or might not be the case. As you know, I don't know which clinic they are sent to, but if it's Korle Bu where I work, obviously there are a lot of patients. We try very hard to see patients as quickly as possible. I'll say that again, just like in referring emergencies, if you know where you are referring the patient to, sometimes it's a good idea to just give us a call, so that we make sure that we see the patient as quickly as possible. Indeed, we can start patients' treatment within a few days of the first time we see them. It's good if you're a doctor refer a patient to do some very basic investigations, your mammogram, ultrasound, blood test, and so on. And if we have everything, then often we can start the treatment almost immediately, really. But yes, I admit that some may fall through the cracks.
Thank you very much, Prof. And still with Daniela Santiapia says, is there any regulation or regulatory body that oversees these help in the patient's plight in certain cases? I believe Dr. Aite.
Yes, honestly, I have no idea if there's a regulatory body or not. They are not too much like doctors, I don't think. I know they have organizations that kind of put them together and control their activities, but I don't know that there's an actual regulatory authority that ensures that they do things by the book or whatever the equivalent of the book might be. I do think, however, that we shouldn't ignore them, especially the mental health care workers. They have kind of incorporated them into their therapies and have educated them such that they now believe in the orthodox medicine and they work together. So more and more, I'm thinking that as doctors, we should find a common ground, educate them, and then hopefully we'll get to the point where they are collaborators and not competitors.
Yes, thank you very much. I believe the next one is a comment which might be in relation to the 23-year-old lady we spoke about earlier, but James Clayman says, when the patient within the 20s has this bilateral pain in the breast and ultrasound is normal, one must find out whether it is cyclical, which might be related to the menstrual cycle. Cyclical hormonal changes can cause some congestion in the breast that can cause some pain. Thank you very much. We have an anonymous attendee says, what is the incidence rate for breast cancer in males?
You didn't say who wanted to answer. Well,
Exactly.
we know that
I believe this might, yeah.
globally, we usually say 1% of all breast cancers occur in men. It's the incidence is slightly higher in our population. So it's more like 2% or maybe a little more than 2. But in different countries in Africa, you find very much higher rates than you find globally. So yes, in Ghana, it's around 2 to 4% of all breast cancers. It's not 2% of men will get breast cancers. It's that if you take 100 breast cancer cases, then 2 to 4% of them will be men.
Thank you very much, Prof. Bernardonu says, please, do we have care providers trained to offer the important supportive care and interventions in our hospitals? Dr. Ayete, don't know if you can
But I thought
take
you would
this.
answer that.
I was about to.
So, of course, Abuna is what I was just telling her how much I've missed her. So we do have some support staff, doctors, nurses, psychologists, etc., who help with supportive care. It's not the best compared to the rest of the world, or at least the developed world, but we do the best we can. We need improvements though. I don't know if you've tried to seek social welfare support for an older patient. It's hell. But I'm hoping that as our prevalence rates go up, it will become more imperative and policy makers will see the need to improve the support care group. I must say that there are NGOs that give support, please, and you should involve them when you have patients who've been diagnosed with breast cancer, whether it's just support from other survivors or certain activities that they sometimes they take them out. They offer them prosthesis, alopecia, they provide them with wigs and things like that. So it might not be a systemic way of supporting the patients, but there are alternate ways of providing support to your patients. But I think, Abna, it would be good for you to answer the rest of this question.
Okay, all right. I will just add Benedicta Ajimambwachi's question since it's in the same light, and then I'll answer both. Thanks for the presentation. Do you necessarily need to meet the palliative team despite being diagnosed at an early stage? And what benefits does this come with? Yes, so we're advocating for early palliative care, actually palliative care starting at diagnosis. And when we say there are levels of palliative care, we have primary palliative care, which is just having that knowledge as a healthcare worker and sharing that knowledge with your patient, all the way to even quaternary palliative care, which may be a more specialized, advanced palliative care provision. What we're saying is that let the patient know about what palliative care seeks to do, and that is to improve their quality of care. Tell them what they may expect, so that when it gets there, it doesn't become something new to them. Most of our referrals are advanced. That's to the palliative care clinic. But what we're saying is that palliative care is just about improving someone's quality of life. And so if you're communicating well, initially you're addressing their concerns and symptoms, you actually have initiated palliative care. You may send them to the specialized palliative care team in the advanced stages where you feel that the team would have more to offer to the patient than you would have as a primary care provider. Yeah, so the early integration helps. They are not seen as a new team that comes at the end, but they are seen as a team that has been part of their care right from the initial stages, but may not have made as much input as their primary team member. Thank you. So the next, still from anonymous attendee, please, is there a form to fill to get the credit points? You'd have to register, and once you register and provide your MDC or NMC numbers, yes, it would be picked. How do you handle a patient who at the time of encounter says she's not ready to receive the bad news you have for her? Dr. Amu, can you please take this?
Yeah, so thank you very much for the question. And just like I mentioned in the presentation, if the patient is not ready, then you have to wait. So you probably will want to reschedule, the meeting to another day and let the patient, have the time to really reflect on whatever it is that she's thinking about. But as much as possible, once the patient says, "I am not ready," you cannot go ahead. And it is also very likely that once the patient says, she's not ready for the news, it means that she probably has an idea that this is what, you are coming to see, and she just doesn't want to hear it. So you need to give the patients a little bit of time. And then, but such a patient should not be lost to follow up. In as much as the patient is not ready, you want to give the patient a little bit of time and then schedule the patient at a time that probably she's ready to receive the information. Thank you.
Thank you very much. Thank you, Dr. Amu. Grace Fiado would like to know how practical bereavement support is. She acknowledges it as a good thing to the surviving families, but wants to know how practical it is in our setting and who bears the costs of bereavement support, if any.
And that's a very good question. I remember during during my residency program, we did a couple of home visits. So we had patients that were visiting at home who had advanced breast cancer, and when the patient eventually passed, we also went and then visited the family, just to commiserate with them, find out how they were dealing with the loss and all of that. But then, yes, in terms of who bears the cost and how practical it is, I must admit that it can be challenging, especially if you find yourself in a setting where you are constrained with respect to staff and all of that. I know at our unit, the palliative care, team and her team, they do some of these things, but I know it is not that easy. But then as much as possible, it's something that we should try. It may not involve much. For some patients, for some patient relations, they may require a bit more. But yes, there are practical challenges in terms of who pays and all of that. For the palliative team, I believe that whenever they are going for home visits, it's a structured, departmental, activity, which comes with costing and all of that. But yes, I admit that there are some nuances that has to be taken into consideration, and depending on where you find yourself. Thank you.
Thank you very much. The next is for Dr. Aite. Someone wants to know how you cope with the emotional burden that comes with your work, especially when clients have no money for radiotherapy, or the machines are not working and there's a long queue for radiotherapy.
I think that God bless you, God will help you helps a lot, because honestly, I'm not sure how I do it. So there must be an account in heaven for all the God bless yous. But I think that very early on in my training, I decided that my job really is to make life better for people. And I know that I can't save everybody. And I know that I can't provide funds for every sick patient, but I do the best that I can. Sometimes you ask relatives, sometimes you ask friends, sometimes you are offered money from people who just know that you are doing oncology. There are all kinds of ways in which you can receive and give help to your patients. Sometimes it's even just speaking to the support group I spoke to you about. You give a call and they are happy to help because they know that you are doing a good job. And as for the emotional part, I think your character is one, but also the support you have. When you have good mentors and people who support you, somehow you are able to manage even the most difficult of situations. You should ask Prof. Cleglam say some of the difficult situations I get into. But somehow they hold your hand and you're able to navigate.
All right. Thank you very much. We're being asked to advocate for an increase in the number of mammograms in the country as professionals. So, the very last is there any place for digital health, like AI apps, etc., for enhancing the use of family medicine tools for breast cancer? Dr. Amo, can you help us with that? And that would
Please,
be the last question.
Can you come again?
Yes, is there any place for digital health, that's AI, apps, etc., for enhancing the use of family medicine tools for breast cancer? It's talking of digital health for breast cancer, especially when it comes to the family medicine tools.
I'm not really aware of any, specific app in terms of using it for this family medicine tools. But then something just came to mind today while sort of preparing for the presentation. I noticed that when it comes to things like the genogram, the family circle, and all of that, we often sort of ask the patient to draw it. It's more of like a paper-based document. So then I was asking myself, so for example, those who use electronic medical records in LIMS, in Korle Bu and probably other places, how are you going to really practically, do some of this documentation? So probably it's something that we probably need to think about. But for now, you probably may have to maybe do it on a paper, take a picture and then scan it. And then it goes into the records. So that is what I have to say.
Thank you very much, Dr. Amo, and thank you all for your questions. At this point, I would hand over to Prof. Clegg Lamptey.
Thank you very much. I think we've had a good evening. We've had two excellent speakers, and as you can see, they have so much information that they've had to sometimes rush it through so that they can give us as much as we can. I think the message simply is that we have come a long way, but there's still more to be done. Breast cancer has moved on from when it was just one size fits all to a very complex kind of treatment involving surgery. Even the diagnosis alone, it's a whole lot. The radiology and the pathology and so on, the surgery, radiotherapy, chemotherapy, targeted therapies. And then we've also seen that it's not just a question of treating with medication and so on, but we've got to take the whole human being into consideration. The whole person, the psychology, the social, the spiritual, everything has to be taken into consideration. And that's where Dr. Amo's talk comes in very strongly. And we have to make use of psychologists and so on. So that is a big multidisciplinary team which will be involved in breast cancer. And the topic was really looking at breast cancer in Ghana. And we know that a lot of these things we have incorporated into our practice in this country. But as I said, there's still more to be done. And the limitations are there, the financial problems and so on. We can't solve all today. And like Dr. Aite said, we probably can't save the whole world, but we can save some. So anybody we have must make the best we can to save the best, whilst we make efforts to involve the politicians and whoever can, decision makers, to make available things that will help to save more lives from breast cancer. So on that note, I think I'll hand over back to Abena to close us.
Thank you very much, Prof. Clegg Lamptey. Thank you to our speakers, and thank you for everyone who joined. We are grateful. We'll look forward to sharing the next CPD series from Bisayeng. Thank you very much. We'll bring our presentation to an end. Thank you very much. Bye-bye.